there is nothing you don't know about burden of chronic graft-versus-host disease. I'll be brief, and I'll prepare you for next two presentation and question answer. This is my disclosure. I'm one of the volunteers at ASTCT, CIBMTR, and EBMT. Again, chronic GvHD is common. Percentage varies. We don't know the real data, including haplo, but it's still common. I would say it's about 50% of patients developing chronic GvHD. I don't need to go into details about NIH classification of chronic graft-versus-host, but try to use it. Very simple, reproducible, and good quantification of response. Non-relapse mortality, again, relapse-related deaths you don't see much after 2 years or 5 years after transplantation, but non-relapse mortality, probably GvHD-related mortality, continues to rise, never reaching the plateau. And you can see the graph here. 10 years, about 20–30% patients die from chronic GvHD-related complication. And this is important because US aging, this is US data, aging population, you know. We're going to see more and more older adults receiving allotransplantation despite using haploidentical. And this is how you can see, you know, these are two not real case scenario, but this is how you see real clinical practice. So when we present case, you know, in our program, median age gone by more than 10 years in past 15 years. Up to 75, and there is always exception between 75 and excess, 80, if they pass the geriatric assessment. So when we present our case, first question answer asked is, can patient tolerate 1 milligram per kilogram steroid? With increasing age, increasing patient with high HCTCI, we need to take into the consideration. Why GvHD is very important? It's chronic condition. It's one of the most disabling chronic disease we could say. What goes wrong with chronic GvHD-related complication next 30 years? Nicely summarized here. I'm not going to go into the details. We had several presentations on burden of chronic GvHD in the different session. Causes of death in long-term survival, you can see here, most common cause, second malignancy, cardiovascular, pulmonary infection, all linked to chronic graft-versus-host disease. Similarly, quality of life and psychosocial issues are related to chronic graft-versus-host disease. If you look at the second malignancy after allotransplantation, most common second malignancies are linked to HPV, and this is one of our own study when I was at the NIH. Chronic graft-versus-host disease, extensive chronic graft-versus-host disease, linked with HPV-related cervical dysplasia or high-risk HPV-related disease. Quality of life, depression, anxiety, chronic GvHD, biggest risk factor, and it linked with long-term complication. Its burden, late mortality, you know, worse physical functioning, more severe limitations of usual activities, less likely to work. In US, we fill out the disability every 6 months, and this continues. But you know, that's not enough money. And a young patient wants to live a normal life, and those amount of money is not, so they face the financial burden. What is the impact of financial burden? You know, continued disability, minimal standard of living, and they come present with a long date. And some patients will have a delayed psychological recovery also related to this patient, especially those who had a pre-transplantation psychosocial issues. Some patients don't tolerate this one, and they take unexpected route, increases scope. And I still remember, whenever I present, I see the patient's name and face, how they died. I remember in our program. So it's a very sad story for those who had a continued chronic graft-versus-host disease and not able to handle all this burden. Despite, you know, I remember when I presented ground round on complication of chronic graft-versus-host, it was for all the division, Department of Medicine, all division. Our chair was nephrologist at that time, and he asked me a question, If you have those problems, why do you want to do the transplantation? Then I had to tell them, transplantation is better than ever before and safer than ever before. We still have some issue, but we need to address. We are better because we are able to, we know the complication. We preemptively assess the complication and we hit the heart by preemptive screening, preventive guidelines, and selecting the best treatment. This is just a snapshot of our transplant process, transplant operation, which I discussed before also, just for your reference, how we take our patient to the chronic GvHD clinic or long-term clinic, minimizing the financial burden on institution and minimal support needed, because many a times I get questioned, you have a big program, you have resources. Not necessary you have to have a big program, not necessary you have to have resources. If you trained enough staff, low-level staff, nobody is low-level, but enough staff, you can manage all this. And thank you very much for your attention.